So we need to understand pretty clearly what the intent of the legislature was when they passed the act, when they signed the bill, to understand exactly how far the parity is supposed to go with regard to no more restrictive. There's even a bit of confusion over what we mean by mental health benefits and substance abuse disorder benefits. So what gets included? Does autism disorder get included? Does residential treatment for substance abuse in another state get covered? The law provides us with definitions, but those definitions are essentially taken from the plan. So it says mental health benefits are services for mental health conditions as defined under the terms of the plan. And they have to be in accordance with federal and state law, but under the terms of the plan. So there are, I don't know how many plans, Michigan alone, but there's still some uncertainty as to what actually gets included in those mental health benefits, and the same is true with substance abuse disorders. The financial requirement, I mentioned this earlier, is they're referring to deductibles and co-payments and co-insurance and out-of-pocket costs. But there is no change to the aggregate and lifetime limits. So the 1996 law, as it was written to deal with annual and lifetime limits, was excluded from this. There's also an issue with predominant. What is predominant? It's the most common or the frequent. I don't know if many of you have children, but you know when your child asks you something like, so what does it mean? What does a lot mean? You know, does a group have to have three? You know, so it's this kind of interpretation for those of us in academia who still think like we're three. What does it mean to be kind of the most common or the most frequent? Some of these terms are, I think, are well intended, but exactly how they're going to get implemented, there's still some uncertainty. There should be no more restrictive than the other treatment limitations. And so by treatment limitations, they're including limits on the frequency of treatment, so the frequency of treatment, the number of visits, the days of coverage, or similar limits on the scope or duration of treatment. So these are the terms, these are the words that are actually in the Act. The Act does address out-of-network providers, which was an issue with the 1996 Act. If a plan offers out-of-network benefits for medical and surgical services, then it also needs to offer out-of-network benefits for mental health and substance abuse disorders. So the law is specific to say, if you have in-network and out-of-network, you have to have in-network and out-of-network for mental health as well. Now there's a little bit of an out, I guess you could say. There is a possibility that if a plan or an employer with the group of plans determines that in order to implement mental health and substance abuse parity and equity, it's going to cost them more than 2% of what it would have had it not implemented mental health and substance abuse parity. 2% more than the total costs, then they can ask for a cost exemption. And the way the cost exemption works is the plan or the employer would calculate actual benefit costs, which we don't have a definition for, actual benefit costs, and determine that the addition of those mental health benefits has raised their total cost by more than 2% in the first year. After the first year, say they don't go for the cost exemption, or they do, if it exceeds total cost by 1%, they can ask for a cost exemption and not need to implement mental health parity. So it's 2% within the first year and 1% in the subsequent plan year. This cost exemption is only good for a year. So if a plan wants to reapply or wants another year of the cost exemption, then it needs to reapply again. And these numbers need to be actuarially sound, and they need to be auditable. And so the Secretary and the state agencies can audit these cost numbers to make sure that the health plan or the employer is abiding by the rules. There's been a fair amount of research, probably since the mid-'70s, on whether or not having mental health benefits in an insurance package actually does increase cost, whether there's any kind of substitution. If someone uses mental health benefits, do they use fewer medical benefits? There have been kind of direct research on the federal employees plan, because when Clinton passed the federal employees plan to have mental health parity, people have watched those costs. And the cost estimates are much more broad than one would hope, but they vary. It depends on what diagnoses you put into those estimates. Just like we were saying, is autism included in mental health? It depends on what kind of delivery system you're measuring this, how many fee-for-service plans or HMOs or point of service, how managed is the care that they're estimating the costs of. And is there actually an induced demand? Once you have mental health parity, are more people going to seek these services whether they need them or not? So the cost estimates are based on all kinds of ranges in these different variables. But even with these ranges, the highest cost that's been actually audited and established is a 4% increase in total premium, total family premium in a year. And the one that actually gets used more often and seems to have the most support is the 0.1% increase. And so from the research perspective anyway, no one is really anticipating the Mental Health Parity Act to raise costs significantly. So finally, mental health parity is passed. There are many of us who are excited about that, the potential that has for making mental health services available to the people who need them. There is several areas of clarification that we're hoping we get through the regulations to the Act, and hoping to get before open enrollment of for many of your employers. Definitions of no more restrictive, kind of definitions of substantially all. You know, which of these copays are you going to rely on in order to be comparable to mental health? How do they actually calculate actual benefit costs? And we have some work by the Academy of Actuaries from the 1996 bill that's offering some advice to the secretaries on how to phrase that, what the regulations should say for how to actually calculate those benefit costs. Whether they'll be, and how this might affect employee assistance plans. And so I think that the future is bright, or maybe a little foggy, but it's springtime. But you know, as you know, as well as I do, the devil's in the details. And so we'll have to wait and see. So thank you for your attention. Are we doing it time?
I'm impressed with all the guidance for insurance things. What about public health departments when they're offering services to people who don't have insurance? Is there any guidance to them in terms or direction in terms of what of their budget they have to allot to mental health services versus medical services?
Are you saying there'd be a spillover if more mental health services are provided on the private side?
Yeah, and is there anything that says the public health department has to offer services in this way, have to be non-restrictive?
No, not from this regulation, as far as I know. Did you have a comment?
For the benefit of the camera, would you repeat the question?
Oh, certainly. The question was, is there any guidance for public health departments in terms of offering services or allocating budget? Is that correct? Is that close enough? And I was saying from the actual language of the mental health parity bill, there's no direction to public health agencies.
With the passage of the federal legislation, how does that impact what's going on in Michigan? We've had mental health parity legislation introduced here in Michigan.
The question was, how does the federal legislation on parity affect states, and particularly Michigan's legislation on parity? Part of the law does actually say that if states have more strict or more generous, I guess is the term, more generous guidelines for mental health parity, that the federal law doesn't preempt that. So it's the state can still offer more parity or clearer